people who are at high risk for getting HIV. So who are these individuals? Men who have sex with men, commercial sex workers, people who use injection drugs. So these are the individuals who are at high risk for hepatitis B and C viruses. Of course, there are some other groups which are also at high risk, like close household contacts of B and C virus patients. These individuals are also at high risk for B and C viruses. So priority screening services should be offered to them. What are the screening tests that are available for B and C? Nowadays, we have got very good rapid card tests, which are very easy to use and can be used in the most peripheral of levels for screening of hepatitis B and C. For screening, what do we detect? For the B virus, we usually detect hepatitis B surface antigen. And for the C virus, we usually detect antibodies to hepatitis C virus. So these rapid card tests that I have displayed to you are single-use disposable tests. They pertain to the lateral immunofluorescence group, and they are very easy to use. A peripheral health worker does not need any additional reagents except those that come along with the kit, and they can give you results within 15 to 30 minutes. So these are very good screening tests. Their sensitivity specificity is very high. They can be used in the peripheral, even in the field conditions, and you can get very reliable tests for screening. So for B and C virus screening, the take-home message should be that you've got simple tests which can be used by most peripheral health workers, and anyone who is at high risk should be on a priority basis offered these tests. Now, just to recollect who are the ones who are at high risk, we've got pregnant women, we've got people who use injection drugs, we've got healthcare professionals, we've got hemodialysis patients, we've got people who are living with HIV, as well as people who are at high risk of acquiring HIV. So these are the ones who are at high risk, and priority screening should be offered. So if you are a healthcare professional sitting in your clinic, and if you see any of these high-risk group patients coming to you, you must definitely refer them for testing of B and C virus. Moving on to vaccination. Now, the first important message that you need to get is hepatitis B virus, B for Bombay, hepatitis B virus has got a very efficacious vaccine that is available, and this vaccine is provided routinely within the Universal Immunization Program of India. For hepatitis C virus, which is the other virus that I said is very commonly seen in liver cirrhosis and hepatocellular carcinoma patients, this virus does not have a vaccine. So when we talk about vaccination for hepatitis, we are talking about vaccination against hepatitis B virus. So what does this vaccine contain? Now, this is a vaccine which contains the hepatitis B surface antigen viral protein. And usually nowadays, the vaccines that are manufactured are recombinant vaccines, wherein we obtain these protein from culture in the yeast and mammalian cells. So hepatitis B vaccine is a recombinant vaccine. And there are several types of hepatitis B vaccines that are available. These vaccines can either be monovalent vaccines, in which case they have only a single antigen, which is hepatitis B. So the common vaccine which you can see in the market is Engerix B. Whereas for children, when you give it in infants and childhood, usually it is a combination vaccine. That means in addition to hepatitis B, it offers protection against other diseases as well. So the government supply pentavalent vaccine, which is used in the Universal Immunization Program, offers protection against, in addition to hepatitis B, diphtheria, tetanus, pertussis, and Haemophilus influenzae B. Now, if you go to private practitioners, in India, we usually see that private practitioners give a hexavalent vaccine. That means, in addition to the pentavalent vaccine, it offers protection against another disease, which is polio. So injectable polio virus is also a part of these hexavalent vaccines that are commonly given in the private. So for hepatitis B vaccines, we've got three types of vaccines. One is a monovalent vaccine, which is generally given for adults and offers protection only against hepatitis B. The other group is combination vaccines, which in addition to hepatitis B, gives protection against other diseases as well. And these are commonly used within the Universal Immunization Program as well as by private practitioners. So how stable are these vaccines for storage in the most peripheral of health institutions? Hepatitis B vaccine is a fairly stable vaccine, and you can store it at 2 to 8 degrees Celsius in the ice-lined refrigerators, which can be available in PHCs in India. And the only important point that you need to remember is these vaccines are very sensitive to freezing. So at all costs, you should avoid freezing these vaccines. Now, coming on to the dosage is 0.5 ml for any newborn child or an infant that you want to vaccinate. For adults, the vaccine dosage is 1 ml, whereas for hemodialysis and immunocompromised patients, we usually give a higher dose, which is 2 ml. Now, what is the schedule of vaccination, which is more important for you to know? So if you are advising a young mother who's having an infant or a newborn, then the schedule that you must ask her to remember is 0 dose at birth. So within 24 hours of birth, you give 0 dose. And 6, 10, and 14th week of life of the baby, you need to give 3 more doses. Now, the preferred vaccine for the 0 dose is the monovalent vaccine that I spoke to you about. In 6, 10, and 14 weeks, you give the pentavalent vaccine, which offers additional protection against diphtheria, pertussis, tetanus, also against Haemophilus influenzae B. Now, what about the vaccine schedule for adults? So if an adult comes and wants to get vaccinated, or you think that is a high-risk individual who can be offered protection through vaccination, then the dosage schedule that you need to follow is 0, 1, and 6 months. So if today you begin the first, which is a 0 dose, today you give the first dose, which is day 0, then followed by that after 1 month, and then after 6 months. So for adults, usually we prefer the monovalent vaccine. So take a minute and look at this slide, and this is a very important slide. For B vaccine for newborns and infants, it is 0 dose followed by 6, 10, and 14 weeks. For adults, it is 0, 1, and 6 months. So the site of administration, it might be of importance to individuals who offer these vaccines to the patients. So for newborns and infants, we usually prefer the anterolateral aspect of the thigh, and for adults, it is the deltoid region. And we often avoid the gluteal muscles for risk of sciatic nerve injury. Now, one burning question which everybody may be having is, how efficacious are these vaccines? These vaccines are very much efficacious. So studies have shown that giving 3 doses of these vaccines offer 98 to 100% protection against hepatitis B. And 2 doses of vaccines offer 80 to 95% protection. And of course, 1 dose slightly lower efficacy. So if you give the 3 doses, then these vaccines are very good and very efficacious in protecting against hepatitis B. Now, if somebody has a question, like I am a healthcare worker, I have taken the 3 doses of vaccine as an adult. Now, am I really protected? Has the immune response happened in my body? How to test that? In order to test that, you need to take the anti-HBs titer values. Now, this anti-HBs titer values, if you find that they are more than 10, then that indicates that there is an adequate vaccine response. So what does that adequate vaccine response mean? That adequate vaccine response, if you're an immunocompetent individual, it means that you need not take any further booster doses in your lifetime. Why? Because over 90% of people who are immunocompetent and at least one time have a serum level of more than 10, they are seen to be protected for the next 30 years. And of course, you do have cell-mediated immunity, which is not measured here. So the protection lasts for a longer time. So any immunocompetent adult, which most of you would be, if you get your titers checked and the titers are more than 10, you need not worry about getting a booster dose. Now, what about hepatitis B vaccine doses missed in adults? Now, what we usually recommend is if after taking the first dose, the person forgets to take the next dose after 1 month, then the subsequent dose should be administered as soon as the person remembers that he has forgotten to take the dose on the appropriate time. And the interval between the second and third dose should be a minimum of 8 weeks. Now, suppose a person has taken a dose today and 1 dose correctly in the next 1 month, and then has forgotten to take the third dose 6 months later. Now, what to do in that case? So suppose if the person remembers it at 8th month or 9th month, you should administer it as soon as the person remembers and comes in contact with the healthcare professionals. So what about those individuals who have forgotten how many doses they have taken? Like when you sit in the clinics, you might be listening to people who will be, telling you that I have taken probably 1 dose or 2 doses, I do not remember, or they may not have any vaccine history documentation. So if the vaccination history is not reliable or is not really available, then do not hesitate to give additional doses, because administering extra doses of a monovalent hepatitis B vaccine is not documented to be really harmful. So you can go ahead and offer the individual extra doses. So this is another thing that I wanted to clarify through this lecture. Another common question that we get asked is, can hepatitis B vaccine given in pregnancy? Yes, hepatitis B vaccine can be given in pregnancy and in lactating mothers. These two conditions are not contraindications for vaccination against hepatitis B. So a pregnant woman who is at risk of hepatitis B virus should definitely be considered for vaccination if she is not already vaccinated. So who are the women who are at high risk? Pregnant women who might be having more than one sex partner, or who might be, getting evaluated or treated for an STD, or who might have had an injection drug use behavior, or who's got a positive partner, who's got a hepatitis B surface antigen positive partner. So these women definitely must be considered for vaccination if they have not already been vaccinated. Now, what are the adverse events? Now, these are very good efficacious vaccines, which we saw in the efficacy rates. What about the side effects? Really, these vaccines, the side effects are, of course, very mild. And you can see that out of 100 individuals who are vaccinated, usually only 2 or 3 individuals complain about these conditions. So what are these mild adverse events? Usually patients can complain, or beneficiaries can complain of some amount of pain, redness, or swelling in the region where the vaccine is administered. Some people may have a mild elevated temperature, and some may have small amount of headache. The most severe adverse event, which is a very rare event. So if you administer 1 million doses, then of course one individual may very rarely have a severe allergic reaction, which we call as anaphylaxis. So it is for these individuals that the vaccine is contraindicated. So anybody who experiences a severe allergic reaction to hepatitis B vaccine during the first dose, or knows that he has a severe allergic reaction tendency to any of the components of the vaccine, then of course that individual, you should not give the vaccine, and that is a contraindication. Some people might think that hepatitis B birth dose should not be given to premature low birth weight. No, these are misconceptions. So a premature baby, low birth weight baby, small for gestational age baby, baby born to HIV positive mother, or baby who have got neonatal jaundice, all these babies can safely receive hepatitis B birth dose. These are not contraindications for giving the vaccine. So if the child is born slightly prematurely, maybe at 34 weeks, if the baby is low birth weight, maybe 2 kgs, 2.5 kgs, or if it is small for gestational age or has got neonatal jaundice, don't worry, just go ahead and give the birth dose of hepatitis B vaccine. Now, of course, these vaccines are very safe to be co-administered with other childhood vaccines or even adult vaccines, and you need not really worry, and go ahead and you can administer 2 vaccines. So why are we more worried about viral hepatitis? You will be listening later on to Dr. Manya about the burden of the disease. Viral hepatitis, the burden is very, very huge in terms of both morbidity and mortality. So what the WHO did is it brought other collaborators and came out with a global health sector strategy to eliminate viral hepatitis. What this strategy proposes to do is, this strategy proposes to eliminate viral hepatitis by the year 2030. That is 8 years on from now. So they have proposed several important key interventional strategies, which if we do, will lead us to a path where we can, visualize or achieve elimination of viral hepatitis by 2030. Of the several strategies which the WHO has proposed, one of the key important strategies, of course, by now you would have understood, is vaccination against hepatitis B. Now, they have proposed certain targets, which if we achieve on time, we will be on the path to eliminating viral hepatitis. What are these key service targets? These key service targets are pertaining to the 3-dose hepatitis B vaccine as well as the birth dose vaccine. Now, for the 3-dose vaccine, the target that they have kept is by the year 2030, we need to achieve 90% coverage among all eligible children. And for the birth dose vaccine coverage, by 2030, we need to achieve at least 90% coverage. Now, look at what are the estimates available in the Southeast Asian region in the year 2015. In 2015, the Southeast Asian region did reasonably well for the 3 primary doses of vaccination for children. We reached around 87%, which is very close to the 90% target. Whereas if you look at the birth dose, the coverage is very dismal. So for the birth dose, in 2015, the coverage was only about 34% in the Southeast Asian region, where India is a part. Now, more recent reports say that in India, the birth dose coverage is 40 to 45% only. So that is also very, very low. So it is in this area that we must put in all our efforts and energy to improve the birth dose vaccination so that we are on target, or so we are on track to reach the target of 90% by the year 2030, which is only 8 years from now. So what is the actual coverage of viral hepatitis in India? If you look at the latest NFHS, which is NFHS 5 2019 to 21, you can see that the coverage is about 84%. Whereas in NFHS 4, the coverage is slightly lower. So we have improved between NFHS 4 to 5 in terms of the 3 doses coverage. But however, we are lagging behind, as I told you, in respect of the birth dose coverage. Now, why timely birth dose is important? This is a very important slide that I would like to take a minute or two to explain and request your close attention. On the x-axis in this graph, you can see the age at which a person is acquiring hepatitis B infection. On the y-axis, the primary y-axis, you see the percentage of individuals going on to have chronic infection. And on the secondary y-axis, you have got symptomatic infections. So what the graph shows is the dotted lines, the dotted blue line shows chronic infection compared against the age at infection. So suppose if you get infected, if a person gets infected at birth, what are the percentage chances that he would have a chronic infection later on? It is close to 90%. So let us see 1 to 6 months. 1 to 6 months, what happens? Slightly decline, maybe around 78%. And as the age increases, the age at infection increases, the chances of chronic infection declines. So much so that if a person gets infected at adolescence or even at early adulthood, the chances of him getting a chronic infection is lower than 20%. It's close to about 10%. So the key take-home message from this slide is, if a person gets infected early in life, then has got a greater risk for going on to have chronic infections. And mind you, chronic infections is a bad word for liver disease. If you get chronic infections, then the person may most likely proceed to get cirrhosis, or may even, in some cases, go on to get cancer in the liver, which is we call hepatocellular carcinoma. So what we need to do is we need to take serious efforts to prevent early infections. So mother-to-child transmission is something that we must definitely prevent. So what is the weapon that we have against mother-to-child transmission? That is birth dose vaccination. So timely birth dose is one of the key weapons that we have against mother-to-child transmission, and it is a must to administer the 0 dose of hepatitis B vaccine within 24 hours of birth. Now, several studies have shown that if you give the birth dose followed by 2 doses, then nearly 90% it offers protection against mother-to-child transmission. So as I already mentioned, this I'm reiterating, this is where we need to work. Though the WHO advocated for administration of hepatitis B birth dose from 2009, even 10 years, a decade later, we are still nowhere in reaching even 50% coverage. So in India, the coverage is about 40 to 45%, and globally, the coverage was only about 38% few years back. So we need to improve this and somewhere get it closer to 90% if we want to realize the dream of elimination of viral hepatitis. Now, another thing that you could give, which offers additional protection against mother-to-child transmission, is hepatitis B immunoglobulin. But the problem with hepatitis B immunoglobulin is it is very costly, and many a times it is not available in the most peripheral of areas. However, if you are working in a center which does have hepatitis B immunoglobulin, the only caution that you need to follow is the vaccine. The birth dose vaccine should be given in one limb, and you should give the immunoglobulin in the contralateral limb. And always use 2 different syringes for giving, one for giving the vaccine and another for giving the immunoglobulin. So to summarize what I discussed with you about vaccination, hepatitis B, if you want to eliminate, the only important intervention that we need to do is vaccination. This is a very good weapon in our arsenal, and it has got a very good protective efficacy of even to the level of 95%. And it's a safe vaccine, and there are no serious side effects for the vaccine. So if you concentrate on birth dose vaccination, then birth dose can definitely help you prevent against mother-to-child transmission. Because if a child receives a timely birth dose and 2 additional doses, then there is 90% efficacy in preventing mother-to-child transmission of hepatitis B. And if anyone wants to check if they are adequately protected after getting the full schedule of vaccination, then they can go ahead and test anti-HBs titers. And if an immunocompetent individual has a titer of more than 10, then he is got adequate protection from the vaccine and need not worry for the next 30 years or so, or even more than that. So you need not consider booster doses in immunocompetent individuals who have shown good response to vaccination, that is having an anti-HBs titer of more than 10. So these are the key messages that I wanted to leave you with after vaccination. Just to touch upon the importance of health education for viral hepatitis. Now, hepatitis B and C are important diseases because they have got high burden. And there are effective strategies, which also subsequently the speakers will talk to you about. In addition to vaccination, there are several other effective strategies. We've got very good treatment options. So those will be covered by the next. But of course, health education is important because making people aware that viral hepatitis is an important disease. And of course, people should not discriminate against viral hepatitis. These are 2 key messages. And these health education efforts, ILBS is really in the forefront in the country. So they have done several strategies like posters, competitions. They're having brand ambassadors, using social media, running campaigns, bringing stakeholders onto a platform. Now, these are several of the most time-tested methods for doing health education. Just want to take you through the efforts of ILBS because it's really a commendable effort what they are doing through the empathy campaign. And one of the key areas they want to focus is, of course, removing the discrimination from the patients, but of course also to promote the awareness about the disease. So they have developed several posters on key topics like viral hepatitis is curable, or getting tested for mothers, or vaccination at birth, or even general posters which talk about health education related to viral hepatitis. They have conducted several innovative competitions, and one very innovative one which I liked is the cartoon competition that they conducted. Over 40 people from over 40 countries participated in this competition and came out with really good cartoons which could be used for health education. Another interesting initiative was the Happy School initiative. I was fortunate to be a part of this initiative. This one ran in this government schools of Delhi. So through this initiative, all the Delhi government school principals, teachers, and sometimes even students were involved in activities, and awareness was spread, and message of why viral hepatitis is important, how it can be eliminated from the society were discussed, and these key deliberations, I'm sure, helped improve the awareness about viral hepatitis in the key stakeholder group of teachers and students. Of course, Empathy Campaign has got a brand ambassador in the form of Mary Com, and she constantly tweets and uses her social media platforms to spread awareness about viral hepatitis. She also figures in several of the health education videos which ILBS has prepared. Another important repository of information is the faculty videos, which are available from the ILBS faculty. So eminent faculty like Dr. Shiv Serene, Dr. Ekta Gupta, who are really experts in this area, are available on the Empathy Campaign website, and you can see on their YouTube channels as well. So these videos provide you really good quality information about viral hepatitis. And the Empathy Campaign runs several I-Pledge campaigns with partners from and stakeholders from across different walks of life. So these campaigns also help in improving the awareness. And of course, they have not forgotten to include the policymakers in their initiatives. So they have done several activities involving key parliamentarians. You can see that several of the key ministers and parliamentarians have been brought onto a platform to discuss the importance of viral hepatitis, what needs to be done to improve the condition of the patients. So they are very active on social media platforms. They've got a web page. They are active on Twitter, Facebook, and they're even running a YouTube channel. So I think these are important initiatives when we go ahead in the future in order to eliminate viral hepatitis. So my congratulations to the Empathy team, and I thank you all for giving me this opportunity to share my views with you on this very important webinar. And I hand over to the organizers. I think we'll be taking the questions during the Q&A.
Yes, ma'am. Thank you so much. Thank you so much, Dr. Archana. Yes, we will be taking the panel discussion, and anyone of you, if you have questions, you people can post that in Q&A section also. Before going ahead with Dr. Ajit's talk, I would like to announce, like, we have got only 23 responses for the form we have floated, pre-webinar assessment form. So I request you all to please finish that. We are not going to judge you on the questions. So students, please don't feel shy in filling that particular form, because if you don't fill both the forms, you will not be getting the certificate. So going ahead in our today's session, I would like to invite Dr. Ajit Singh Badodria, who is an associate professor in community and family medicine from AIIMS Rishikesh. He is a MBBS from Government Medical College Gwalior and MD in community medicine from Jabalpur. He has more than 5 years of experience at Apex Liver Institute of Country, ILBS New Delhi, as epidemiologist and project coordinator to WHO Collaborating Center on Viral Hepatitis. So as we all know, WHO gives us many policies related to pandemic and all the diseases which can be spread. So he has worked there and he has published more than 100 scientific papers. He was the recipient of ICMR Professor B.C. Srivastava Award in year 2016, and with WHO headquarters, he has worked on guideline development group member of HCV self-testing, guideline development group member of Hepatitis C, technical working group member of HCV self-testing, and developing SOP for enhancing reporting of acute hepatitis as scientific committee member from SCAR. Today, he will be giving his good talk about the transmission and prevention of HBV and HCV at community level. So you people all being the budding nutritionists and the stakeholders, so we all can learn the same thing from Dr. Ajit, and we can prevent hepatitis B and C from the community. Thank you so much, sir, for sparing your time.
Thank you so much, Dr. Ankita, for introducing me. And a very warm good afternoon to all of you. And I'm really very grateful to Umesh Kapil sir, Dr. Sareen sir. Both are my mentors and guides. And fortunately, I've worked under the guidance of both these stalwarts. So I thank Team Empathy at ILBS for providing me this opportunity to contribute in the very useful this series of webinars targeting awareness, dissemination of knowledge, as mentioned by Dr. Archana, that health education is very important. So building capacity of not only doctors, but for all for hepatitis B and C. And I'm sure that this will definitely going to play a major role if we are targeting elimination at large by 2030. So in today's session, I'll be talking about the modes of transmission of hepatitis B and hepatitis C. So before starting it, I'll like to just tell you that it's similar to HIV. So keep in mind how HIV transmits, and then I think this presentation will be useful to you. So let me try if it can go for slideshow, Aisha. Otherwise, I'll continue similarly with this screen only.
So your screen is visible to us. You are
is it in slideshow?
Yes, sir. No, it is not in slideshow mode, but it is visible to me.
Right. So I'll be what I'll be covering in the session is that I'll tell you about modes of transmission of hepatitis B and hepatitis C, and then we'll talk about how we can prevent this transmission which is occurring for hepatitis B and C by general precautions. Vaccination, you already have heard a lot about vaccination from Dr. Archana. I think that's a strategy which is very useful if you want to prevent hepatitis B transmission in the community, and if we want to decrease the incidence of hepatitis B. Then we'll talk about post-exposure prophylaxis for hepatitis B, because this will definitely help in preventing the transmission among healthcare workers, because we work closely with patients, and if somebody is infected and by any mode, if we get in touch with blood or body fluids, there can be a chance of transmission. So if we know that we are exposed, we should go for post-exposure prophylaxis. So we all know that hepatitis virus, which cause hepatitis, means hepat means liver, itis means inflammation. So viruses which causes inflammation of liver, they are known as hepatitis viruses. There are majorly 5 types of hepatitis viruses: A, B, C, D, and E. First and last, fecal-oral transmission, transmitted by contaminated food and contaminated water. So A and E, they are transmitted by contaminated food and contaminated water, similar to typhoid, similar to other gastro and intestinal diseases. Middle 3, B, C, and D, they are parentally transmitted. That means they are transmitted through blood, through body fluids, through unsafe sex practices, through unsafe injection practices, similar to HIV. So these are the most common mode of transmission for hepatitis B, hepatitis C, and hepatitis D. So why D is not included in this this webinar? Because D is a defective virus. So D virus cannot cause mono infection. So it cannot cause an infection by itself. D always needs B. So D needs B and then causes an infection which can be a co-infection occurring along with B, or can be a super infection occurring on already existing B infection. So D is similar to transmission in terms of transmission. It is similar to B and C, but yeah, it is related mainly to B and causes co and super infection. So parental transmission, if we can divide them into 4 types. So first is blood-borne, which is the most common mode of transmission for hepatitis C. Second is sexual transmission, which is seen also for HIV, also for hepatitis B, and also for hepatitis C. Then perinatal transmission, as was discussed by Dr. Archana also, that mother-to-child transmission is a common mode of transmission, and this is the most common one for hepatitis B. This is also known as vertical transmission, mother-to-child transmission. So vertical transmission. And then 4th one is horizontal transmission, which is occurring among closed contacts or household contacts, where children or people, they live together, they share toothbrush, they share razors. There might be some exposure of infected blood to each other, and they can transmit hepatitis B and hepatitis C and hepatitis D horizontally. So this is known as horizontal transmission. Then the most common mode for hepatitis C, I said that it is blood-borne. It is also a common mode for hepatitis B also. So what happens when we transfuse blood or blood products? So when we transfuse infected blood or blood products from a person to a recipient, then we transmit infection also. It can be due to other modes also, like hemodialysis, multiple blood transfusions, unsafe injections, like somebody who's not using a different syringe every time, maybe a private health care provider, maybe somebody who's not aware about such kind of transmission. So unsafe injections in healthcare settings can also lead to transmission of hepatitis B, C, and D. Needle stick injuries. You might have heard among your colleagues who are working in clinical settings that needle stick injuries are also very common. Most of the times they go unreported. We don't even go and report also. We don't even know also that it should be reported. So needle stick injury should also always be reported, and always the person should be evaluated. Even the person, the patient should also be evaluated for hepatitis B, hepatitis C, and HIV, so that the proper post-exposure prophylaxis can be given to the person who had that needle stick injury. Hepatitis B and hepatitis C can also be transmitted by surgery through equipments, or through I mean, at that time, whenever there is equipment which is not properly sterilized. So if there is unsterilized equipment and that is used in surgery, there might be a chances of transmission of hepatitis B, C, and HIV. Dental procedures, there also leads to transmission. Similar approach like surgery, that is contaminated or infected instruments. Organ transplantation can also lead to transmission of hepatitis B, hepatitis C, and D. So this slide tells you mainly about different modes of transmission for hepatitis B, C, and D, which are very much similar to HIV. You need to remember that vertical transmission, mother to child transmission is most common one for hepatitis B, and blood-borne through unsafe injection is most common for hepatitis C. So if we talk about mother to child transmission, why it is more common in developing countries, why it is more common in India? So it's more common because we have high birth rates. We have low institutional deliveries. Still institutional deliveries, they are not 100%. So newborns who are not delivered at institute, they do not get proper care. So there are higher chances of transmission of mother to child transmission of hepatitis B. Then poor antenatal care in developing countries, poor birth hygiene, poor coverage of hepatitis B birth dose. We'll talk about in detail about hepatitis B birth dose, what is timely birth dose, and how and why this is important. Then low hepatitis B surface antigen testing. So every pregnant female is not tested for hepatitis B. So this we need to incorporate in the system, that every pregnant female during ANC care should be tested for hepatitis B. Because then if we know that a pregnant female is hepatitis B positive, we can provide hepatitis B immunoglobulin within 48 hours so that we can prevent transmission. So if we want to prevent mother to child transmission, what we need to do first is every ANC or every pregnant female should get tested for hepatitis B surface antigen. Every newborn should get a birth dose within 24 hours. And every newborn who is born to a mother with hepatitis B infection should also get a hepatitis B immunoglobulin within 48 hours. So that's as discussed by Dr. Archana also, we should give hepatitis B vaccine in one thigh and hepatitis B immunoglobulin in the other thigh of the newborn if we want to prevent mother to child transmission when we know that pregnant female or the mother is hepatitis B positive. So most common mode, mother to child transmission. Most common approach, test the female and give birth dose and immunoglobulins if required. So how to prevent hepatitis B infection in general? So most important strategy or most effective strategy is vaccination. Birth dose is very important. That should be timely. Timely means within 24 hours of birth. All 3 doses as mentioned by Dr. Archana at 6 weeks, 10 weeks and 14 weeks should be given in the pentavalent form in India. So they should be given to all newborn. And then healthcare workers should also be vaccinated. High risk groups, which we know they are similar to HIV, people who inject drug, commercial sex workers, maybe those who need multiple blood transfusion, healthcare workers, they are also mentioned over here. They all should get vaccinated. And then we go and check the antibody titer of these people because they are regularly exposed to hepatitis B infection. So if antibody titer for surface antigen is more than or equal to 10, we can be assured that the person is safe or person is protective from hepatitis B transmission. Other than vaccination, other strategies, they are similar to HIV, hepatitis C, safe blood, safe injection, occupational safety, harm reduction. I'll tell you more about harm reduction in subsequent slides, and safe sex. So these are the strategies to prevent hepatitis B infection. So hepatitis B, what is the current status? We have seen in the last presentation also, like currently it is around 80, it's more than 80%. Target is to achieve 90% of coverage of 3 doses of hepatitis B vaccine. So I hope that we will achieve this target and by 2030, and this can help us in contributing in eliminating hepatitis B by 2030. So why we want that high vaccine coverage? Because in this slide, you can see on y-axis, this side it is vaccine coverage, on y-axis, and on this side it is chronic infection. So chronic infection is depicted by this black line, and vaccine coverage in terms of 3 doses by blue line, in terms of birth doses by orange line. And on x-axis, you can see year of birth. So from 1990 to 2014, as the coverage of 3 dose, as the coverage of birth dose is increasing, you can see a steep decline in the number of chronic cases from 50 lakh to 5 lakh. So that is the huge impact of vaccine on hepatitis B incidence. Reduction of new cases of hepatitis B, reduction of new infections of hepatitis B. And we target more than 90% reduction. so that we can achieve elimination for hepatitis B. So vaccine can play a major role in achieving that target. So this graph you have already seen, Dr. Archana has beautifully explained it in simple language that if hepatitis B occurs early in life at birth, chances of converting into a chronic infection is high as 90%. More early infection, more chances of chronic infection. If the infection occurs in the later part of life, this chronic infection conversion decreases with time. So I'll say if we can prevent mother-to-child transmission, we can prevent most of the chronic infections. We can prevent most of the infections converting into cirrhosis, converting into liver cancer, converting into mortality. So mother-to-child transmission prevention by vaccination can be a very useful strategy, not only in preventing new infection, but also in preventing death in future. So that's why timely birth dose within 24 hours is very important. So what is the current coverage of hepatitis B birth dose? It's very poor, it's very low, it's around 38%. So only 38% of newborns, they are getting birth dose. So we have to target this particular intervention so that if we can increase this to 90%, then we can prevent a lot of hepatitis B transmission. We have the target is to increase it to more than 90% by 2030. Looking difficult, but if we have done for 3 doses, we may do it for birth dose also. So suppose if there is an exposure occur to a healthcare worker to hepatitis B patient, then what can be done? If the person is unvaccinated, then give hepatitis B immunoglobulin stat and start hepatitis B vaccine series. That is 1 now, 0, 1, and 6. So immunoglobulin plus hepatitis B vaccines, all 3 doses, if the person is unvaccinated and now he is exposed to hepatitis B by any mean. Then if the person is previously vaccinated and we do not know antibody titer, get the antibody titer done. If the titer for hepatitis B surface antigen is more than 10, we do not need to do anything. This infection may act as a booster for that particular person. If the titer is less than 10, then we can go for immunoglobulin first dose and a booster of vaccine. So this is the strategy for post-exposure prophylaxis for those who are exposed to hepatitis B during their clinical practice or during any event in the life. So how we can prevent hepatitis C transmission? We know about the mode of transmission of hepatitis C. They are all which are similar to HIV, and I've told you that most common mode is unsafe blood and unsafe injections. So prevention can be done by giving safe injections, giving safe blood in 100% cases. So if we can improve this safe blood and safe injections to 100%, we can reduce most of the hepatitis C transmission. Then this harm reduction. Harm reduction is when we provide some kind of intervention so that the harm can be reduced in that person. So harm reduction is mainly for hepatitis C. It is done in people who inject drugs, where we provide them sterile needle and sterile syringes, around 300 per year per person, so that they can stop sharing of needles. These intravenous drug users, they share needles, and when they are sharing needles for their addiction, they transmit hepatitis C infection to each other. So if we can provide free sterile needle and syringes to this group, around 300 per person per year, we can reduce the transmission occurring in this group because of this sharing needle habit. Safe sex is also an important strategy, not only for hepatitis C, but also for hepatitis B. Then this test and treat, this is also very important. We know that now we have drugs which can cure hepatitis C, right? So hepatitis B is not curable. Hepatitis B, once it's there, we can only control it. So hepatitis B, like diabetes and hypertension can only be controlled. But hepatitis C can be cured by giving simple oral drugs for only 3 months of period in maximum cases. So test and treat can be a very important policy if we want to prevent hepatitis C transmission. How? Go identify people who are infected with hepatitis C, test them, and if they are hepatitis C infected, treat them so that they'll not transmit this disease in the community. So test and treat policy is important. So just to summarize, hepatitis B and hepatitis C, they are parentally transmitted, similar to HIV. Hepatitis B infection, if occurs early in life, in early childhood, the chances of converting it into chronic infection are very high as 90%. Vaccination is the most effective strategy to prevent hepatitis B transmission. If we give timely birth dose along with 2 additional doses of hepatitis B vaccine, 90% of mother to child transmission of hepatitis B can be prevented. If antibody titer of a person is more than or equal to 10, that indicates adequate protection. Safe blood, safe injection, safe sex, they are effective tools, effective intervention strategies to prevent both hepatitis B and C. And test and treat policy is the best strategy for hepatitis B and C. Why? Because both are mainly asymptomatic. So people who are infected with hepatitis B and hepatitis C, they do not know, they do not have any complaints. They're living their life normally in the community and transmitting infections. So if in such case, we have to go out, we have to find out the hot spots, the areas where hepatitis B and hepatitis C prevalence is very high. You have to screen the people of that area, pick those who are infected, treat them so that we can block transmission. So that's all about modes of transmission for hepatitis B and C and how we can prevent transmission of hepatitis B and C at community level. And we can have questions during panel discussion session. Over to you, Dr. Ankita.
Thank you so much, sir. That was really very nice to know how we can prevent ourselves from hepatitis B and C. Of course, my students must be having some questions. Please post your questions in Q&A section so that we can answer those questions side by side also. Thank you so much, sir. Next, going ahead, I would like to invite Dr. Manya Prasad. Dr. Manya is Assistant Professor for Clinical Research and Epidemiology in Institute of Liver and Biliary Sciences. She has 35 national and international articles in Medline Index journal. Her H index is no doubt is very, very good what all of us want to achieve for. Her area of interest for research is epidemiology, medical research, systemic reviews, meta-analysis, and evidence-based medicine. She has facilitated many workshops on research methodology and evidence-based medicine. She is a gold medalist in her MD and she is a recipient of International Epidemiology Association Fellowship. Thank you so much, ma'am, for sparing your time. Today, Dr. Manya will be talking about the burden of HPV and HCV in India. Dr. Manya, we would like to welcome you for this particular session.
Thank you so much, Dr. Ankita. And once again, I extend my gratitude to Manav Ratna University for jointly collaborating and holding this webinar for our esteemed colleagues. I also thank Rizvi sir for his interest and his support in this academic activity. And you would have realized by now that this is a disease that requires a multidisciplinary approach. And we're so grateful to the Faculty of Allied Health Sciences who are here with us today to discuss this very important topic. So after you've been equipped with the information on modes of transmission and some best by strategies for prevention, what I've been asked to talk about is the current disease burden of hepatitis B and C in India. And what this will contain is a little bit of background on why you should worry about this. And some reported estimates of the prevalence of chronic infection in India of hepatitis B and C. I will do a critical review of the current literature, also talk about some limitations of the current evidence for this. It will be followed by estimates from recent studies and the rate of liver complications, and I'll finish off with some steps needed. So why do we need to worry about hepatitis? Well, because it's one of the leading causes of mortality worldwide. And it's certainly a very important public health problem in Southeast Asia, of which India is a part. It's one of the communicable diseases where mortality is seen to be increasing, and it is responsible for as many, if not more, deaths annually than TB, AIDS, or malaria. Around 90% of these are due to hepatitis B and C infections. However, we need to focus on this because this is actually a disease that can be easily prevented and controlled. So we have a very effective vaccine for hepatitis B. We have a cure for hepatitis C, and we have good drugs now that can manage hepatitis B as well. And so this is actually something that we can do a lot about. And so we need to turn our attention to all of these measures. In terms of how the pandemic has impacted the elimination efforts worldwide, well, COVID-19 has posed a major challenge in achieving hepatitis elimination because important strategies such as vaccination and screening and health education have been severely interrupted, and they've suffered huge lapses in terms of momentum now. It's documented that hepatitis has suffered among the highest disruption of all diseases. And this has been more severe than that for HIV, malaria, and tuberculosis. So it's about time that we shift our focus back. When we talk about the burden of chronic hepatitis B and C, what we're worried about is not just the disease hepatitis itself, but also the very, very serious complications that result from chronic hepatitis. So there are some hepatitis that are acute, which means there's just a fever and a jaundice and malaise for a few weeks and the patient recovers. But what B and C cause is chronic hepatitis. So the inflammation persists in the liver, and with long-standing inflammation, the healthy liver tissue gets replaced by scar tissue. So that's called fibrosis. And over time, this fibrosis leads to irreversible damage in the liver, and that is called liver cirrhosis. And a large proportion of the mortality that's attributable to chronic hepatitis is due to cirrhosis. Long-standing cirrhosis over time can lead to cancer. So hepatocellular carcinoma is the specific cancer. And you will see from the numbers that I will tell you later on that hepatitis B and C are very, very important causes of both of these very serious liver complications. That's liver cirrhosis and hepatocellular carcinoma. So if we talk about the worldwide prevalence of hepatitis B, there are 296 million people who are living with chronic hepatitis B over the world, and 68 million with chronic hepatitis C. The WHO estimated in 2015 that viral hepatitis was responsible for around 1.4 million deaths worldwide. And hepatitis B in 2019 resulted in an estimated 820,000 deaths. And most of these deaths are from those two liver complications that I told you, that's cirrhosis and hepatocellular carcinoma. So huge numbers there in terms of the burden. Up to 40% of chronic hepatitis B develop serious sequelae during their lifetime, so cirrhosis and HCC. And that's a huge proportion. And cirrhosis accounts for 720,000 of the deaths in these infections, and hepatocellular carcinoma for around 450,000 deaths. So again, you can see huge numbers there in terms of mortality as well. So this is the spread of the number of cases across the various WHO regions. So total 296 million. And then there are some WHO regions that bear more of the burden. So African region and Western Pacific, very severely affected. And Southeast Asia also, which has 60 million cases of chronic hepatitis C. For hepatitis C, overall, there are 68 million cases. And again, there are some regions that are affected more. So Western Pacific, again, European. But Southeast Asia region, again, 10 million cases, a huge burden there. Within the Southeast Asia region, you can see this is the prevalence from the from studies that tell us the prevalence of surface antigen. That's how we measure the prevalence of chronic hepatitis B. And you can see here that there are some countries that are affected more. So Indonesia, Myanmar, Thailand, Bangladesh, etc. face a high burden of disease. India, I will tell you more about this estimate in subsequent slides, but this disparity is also there for hepatitis C. So again, some countries facing higher burden than others. So if we come on to the prevalence of chronic hepatitis B in India, there are 3 research groups broadly that have provided estimates of the prevalence of chronic hepatitis B. And these are Schweitzer et al. This was a paper that was published in The Lancet in 2015. The WHO, of course, that engaged a number of agencies to arrive at a summary estimate. And then there's the CDA Polaris group. So what you see here in the middle is the point estimate from these studies. So that's sort of like the best guess. And then in the bracket, you'll see the confidence interval. So this is the sort of margin of error, right? So the true value can lie from this to this. So you'll see that broadly close estimates from three research groups, 1.46% for India from Schweitzer et al. And the WHO 1.95 with a very large overlap in the confidence interval. And again, the CDA Polaris group also. Just a word about what these studies did. They all reviewed published literature. So, maybe these databases sound familiar to you. We often go to them when we are looking for evidence on a certain topic. So all of them have made systematic summaries of the current evidence on the prevalence of hepatitis B. And the systematic review is basically a study of studies. So they've systematically summarized these studies out there. And some have also included unpublished studies. In terms of who they included in arriving at those estimates, most of them have excluded high-risk populations. So all 3 of them excluded migrants, refugees, non-representative populations. And they differ slightly in the countries that they have included. So in case you were wondering about what those studies are have done, this is what they've done. These differences in methodology can slightly explain that discrepancy that is there in the point estimate and confidence interval. So this study is purported to be the most reliable estimate, and it summarized 129 studies and 3.7 million subjects. And this prevalence that they reported was 1.46%, which accounts for 17 million chronic carriers of hepatitis B in India. If we look at the change over these 2 time periods, so 1950s to 1980s, it was way higher. So you can see that compared to a decade before, there has been a reduction in the prevalence of chronic hepatitis B, and this can possibly be attributed to vaccination. And this is also supported by the WHO estimate from the pre-vaccination era. The 2019 estimate shows a reduction certainly in all ages as well as under 5 age group. And this can again possibly be attributed to the vaccination out there. So again, strong measure for reducing the prevalence of disease. There are a number of recent studies that have been conducted in India on the burden of hepatitis B. And what you will notice from this table and the next 2 slides is that there is high level of inconsistency in who they've included, first of all. So some have included general population, some children, some patients, some eye donors, and some blood donors. And they also differ significantly in the method of testing. So while some use surface antigen, ELISA, and others use immunoassay, etc. And so there still isn't a very robust, nationally representative study that can tell us or give us a very, very reliable estimate of the prevalence. But this is what is out there with high heterogeneity in terms of a number of things, and that can possibly explain the discrepancy in the estimate that is reported. If you talk about the prevalence of chronic hepatitis C, again, this was a systematic review, and that told us that the prevalence ranges from 0.09 to 15%. Again, a number of types of studies included, which is why there's a broad range. But if we just take the estimate from community-based studies on blood donors and pregnant women, and general population, then the estimate is 0.85%. So this is translates into 6 to 12 million chronic HCV infected people in India. And of these, 3 to 9 million people are living with active HCV infections. And HCV accounts for up to 32% of HCC cases and 20% of cirrhosis. So again, a large proportion of these two liver complications are due to HCV as well. So you can tell that there are some lacunae in terms of studies assessing the burden of chronic hepatitis B and C. You could tell from that table that the quality of reporting is highly variable, and they've often combined robust and non-representative studies, included different age groups, different time points. And we don't really have data on age-specific and sex-specific estimates. So if you want to know whether there's a gender difference, we can't say that for sure. And there are studies that very often have excluded or have not been done in young children. So we don't know the estimate for that strata as well. Healthy donor effect, or the studies that have been done in blood donors may be yielding an underestimate because they may be healthier people. And most of the estimates are from subnational level, with some targeting very high endemicity areas like tribal areas. So coming on to the mortality, if you look at this graph, it will tell you the proportion of deaths that are due to cirrhosis and hepatocellular carcinoma in HBV and HCV. So the darkly shaded one is cirrhosis and the lightly shaded one is HCV. And you can tell that a large proportion of the deaths in both of these infections are due to cirrhosis and HCC. And if you want to know the absolute numbers, this is the estimated number of deaths due to cirrhosis and HCC. And the age standardized death rate, that's per 100,000. You can see a large burden there, 7.8 per 100,000 age standardized death rate for liver cirrhosis. So this was a study that told us what is the change in the incidence rate of liver complications. So this is both cirrhosis and HCC. And we can see here that the worldwide estimate, at least the point estimate, indicates a reduction from 2007 to 2017. However, for India, there's the point estimate points towards an increase, a 7% increase in incidence of liver complications. But of course, this is not a reliable estimate because you can see the confidence interval is very broad. And then this relies on certification of death, which is very poor in India. So that's a huge caveat there. But you can tell from this table at least what does the incidence rate look like for liver complications. And the death rate is on the right side of this. And again, you can tell here that the point estimate indicates a 2% increase from 2007 to 2017. And this trend holds true for both cirrhosis and HCC individually as well. So I will reiterate here the WHO Global Health Sector Strategy on Viral Hepatitis, which tells us about how to achieve elimination by 2030. This entails a 65% reduction in deaths due to chronic HBV and HCV by 2030, and a 90% reduction in new infections by 2030 of chronic HBV and HCV. And the only way to achieve this is through a public health approach. We need a multidisciplinary approach. We need allied health sciences to be aware of all of the measures and strategies for elimination, and we need a commitment from all lines in the medical discipline as well. And the public health approach, of course, will be elaborated more in the next session, which is on the national program. So I will finish here, and thank you very much for your attention. Back to you, Dr. Ankita.
Thank you so much, Dr. Manya. That was, so I guess my students must have learned how the prevalence is changing for HBV and HCV in India, and what is the burden of this particular disease in India. Thank you so much, ma'am, for sharing your knowledge with us. Going ahead for our next talk, I would like to invite Dr. Ekta Gupta. Ma'am is working as a professor in the head and head of Clinical Virology Institute of Liver and Biliary Studies. Ma'am is a MD in microbiology. Ma'am is MD in microbiology from King George Medical College, Lucknow. She has received the Best Scientist Award by ICMR, the institute which does maximum researches, clinical researches in India. She was the technical resource person for developing National Virus Hepatitis Control Program in India. She has several research grants at national and international level for her. She was the course faculty for WHO CC at the institute. She has more than 80 scientific publications in index, national and international journals, and she is the author of more than 11 chapters in various books. Her area of interest for research, the dengue virus. Ma'am is going to share her view on the National Hepatitis Control Program, for which she is the for which she is basically leading this particular program. She was the technical resource person. Thank you so much, ma'am. I know Professor is very busy throughout the day. So again, we can see you in apron sitting your own cabin. Thank you so much for sparing your time with us. Thank you, ma'am.
Thank you for your kind words. And without wasting time, I think I'll start sharing. And good afternoon, everyone. Now, can you all hear me and see my slides? Please let me know.
Yes, ma'am. You are audible, visible, and your slides are also visible, ma'am.
So I think all the sessions have been done. So you guys know what is viral hepatitis, by how many viruses it is caused. So I'll just tell you what the government of India has done. There is the problem of chronic hepatitis B and C on a rise, more than HIV and malaria. And the targets were set by WHO for combating this problem in India also. And our government was a signatory to this, that for hepatitis B and C, the new cases have to reduce and mortality by B and C also needs to be reduced. I think Manya must have touched on to this. How are we going to tackle this problem of hepatitis B and C? We can tackle it by increasing the vaccination, making the birth dose available for hepatitis B vaccination for all children who are born within 12 hours of their birth. We can make since these are bloodborne viruses, we can make safe testing for all units of donated blood for blood safety, ensuring that ensuring that needles and syringes are safe and properly discarded so that the reuse of these injections are not done. Increasing hepatitis B and C diagnosis and offering treatment to those who need in hepatitis B and C. The major gap lies in diagnosis. You have to identify more and more people for hepatitis B and C infection and treat them. In India, you will see a lot of, so there are 5 viruses, as previous speakers must have said. A and E, they cause food and waterborne hepatitis, and they are the causative agent for normal jaundice. So when a patient has got an acute sporadic jaundice, which we call as jaundice, normally in a layman language, that is caused by hepatitis A and E. And that's also a problem, but one can prevent it, hepatitis A and E, by ensuring safe water and other hygienic practices. And for A, you also have a vaccine. B and C are through blood and blood products. So more, and they do not cause frank jaundice. So patient is not usually symptomatic. So you need to identify and screen and then put them on treatment. D is not a problem in India, so far we know. So at ILBS, we have done a lot of collaborative work with through WHO Collaborative Center, Government of India, and we push towards the making of National Viral Hepatitis Control Program. And in the year 2018, finally, the National Hepatitis Control Program was launched. These are the guidelines which are freely available. One can download them and can easily read all of them. These are all freely available. So for hepatitis B, C, A and E, all the guidelines are laid. What are we aiming? Why are we doing this program? Because we have to eliminate hepatitis C. We have to reduce infections by B and C. And we also have to reduce the morbidity and mortality by A and E. What does this program means? There is at the national level commitment by the government of India. They have made the guidelines. They have circulated them. Each state knows what to be done. They have to make these sites and states lab where the testing and treatment for hepatitis B and C and diagnosis for A and E is given. So in this program, we are going to screen all. So we are not going to do a targeted screening for only high risk group, but all for probable infection for B, C, A, and E. And for B and C, confirmation has to be done by a PCR test. Treat all uncomplicated. So if your liver is healthy, you have to treat in a one particular style. But if your liver is more unhealthy, and that means a complicated case, you have to treat the patient in a different way. We are going to adhere to several methods of testing, and usually the rapid diagnostic tests are the simple card test by which we are going to test for B and C. So what are the challenges we are anticipating? We are seeing that once you diagnose a patient and then you have to give them treatment, the continuity might be lost. So you really need a lot of linkage and continuity services. And the treatment should be provided immediately so that they are not lost to follow-up. And the complicated cases should be managed at a tertiary level center like ILBS for all these B and C infections. Hepatitis B virus is a DNA virus, and you all know it is transmitted from the most common route is mother to child. So blood and blood products. So during the time of delivery or post-delivery, the chances of hepatitis B transmission is very, very high. The other routes are through blood and blood products, unsafe injections, dialysis, needle stick injuries. They are also there, but most common route is mother to child. Now, this has got an antigen on its surface, hepatitis B surface antigen, and a DNA inside by which we test that whether the active infection is there or not. So infection is there or not, we do it by just testing in the blood for the presence of hepatitis B surface antigen, and whether this infection is actively happening, so that we test by doing a simple HPV DNA test. This is how this is a natural history for hepatitis B. So I told you, you can acquire it from mother to child, or if you are adult, then how you can acquire? Most common route of acquisition, sexual transmission, unsafe injury, you can acquire. But the chances that it will affect your liver adversely is 95% if you have got it from at the time of birth. If you have acquired it in the early stages of your life, less than 5% chances that you will land up into this grievous kind of an infection. So if you have a less, like in adulthood, you have just got exposed and the virus has not entered your liver, has not established a chronic infection, it will get cleared within 6 months, and we call it an acute hepatitis B. In that case, sometimes the liver failure, less than 1% might occur. But usually it is the chronic infection which is troublesome. And since it is asymptomatic, means the patient will not have any sign and symptom. I might be having hepatitis B infection, I do not know, only when my liver function, and that becomes very, very late stage. So in that case, I'll come to know that I have hepatitis B. So that is why it is advised that at least once a year, you should test for hepatitis B or hepatitis C, whether unfortunately that virus is there in your body or not. Now, this is a management protocol. I don't think so the audience required to know about it. Just briefly, that hepatitis B surface antigen we test, and then then we do a couple of series of tests for putting the patient on treatment. Only one line, that this treatment is lifelong. So when you give an all oral drugs, you offer a treatment, then person has to take it for lifelong. List of drugs which are available, and they're freely available. Hepatitis C virus is an RNA virus, which is a simpler virus, and we test for its infection by just looking at the antibody to HCV. So we do an anti-HCV test, which tells us whether the infection is there, and then you confirm the infection by doing an RNA. This also can get cleared from the body, if you acquire, but the chances that it becomes a chronic infection is much, much higher. In 70% of cases, it might go and become chronic. Means you will have antibody and you will have an RNA. The mode of transmission for hepatitis C, unlike hepatitis B, is more your age. If you are more than 30 years, then through unsafe injections, through hemodialysis, through blood-borne practices, the chances of acquisition of hepatitis C becomes more. And if you are older, more than 30, the chances that you'll have a chronic liver disease because of hepatitis C becomes higher. We only look for antibody to hepatitis C, and then we check for an infection, active ongoing infection, by doing an RNA test, and then we give treatment. Treatment is given by these drugs, which are freely available, and it is given for a 12 weeks. So 3 months course of all oral. So you don't have those painful injections. You have those tablets which you eat for 3 months, and then you get your RNA test again. And if it is negative, that means the virus is cleared. So it is a nice virus, better than HIV and hepatitis B, that it gets cleared totally from the body. It does not remain. But B and HIV, once infected, they remain. Although the prevention for B is available, which is a good vaccine, but it's difficult to cure hepatitis B totally. Hepatitis E, as I told you, it is a normal jaundice caused by water and food. And so when you acquire this infection, you have that typical jaundice, that is, your liver function is deranged, you'll have high bilirubin, yellow eye, yellow colored urine, and all those things, loss of appetite. And how do we diagnose? We just do a blood test, which is known as IgM antibody to HEV to diagnose. But the good part is that it on its own gets cleared within 3 to 4 weeks time. You actually do not require a treatment. You just require a good dietary support and some other symptomatic management. No antivirals are needed. Same as hepatitis A. A is more of a problem in children than adults. And this is also a conventional jaundice, means yellow color eyes, urine, loss of appetite. And we do the testing by doing an HAV IgM test in the blood. But the virus clears off on its own in 3 to 4 weeks time. And you do not require an antiviral treatment. You just need to know that there is a viral hepatitis. So this is the algorithm. So if you have a jaundice person, means he is having visibly yellow colored urine, eyes, and all those things, you need to test for all 4 viruses. D we do not offer because D is an incomplete virus, which can infect only those who are infected with B. So once the B infection has to be established, and then you can do, but A, E, B, and E by simple blood test we diagnose. But most important is those who are asymptomatic, means a healthy person not knowing that has got any jaundice or anything. We test for B and C. We do, and as I have told you, how do we will confirm their active infection, and we have to put them on treatment. And for B, the lifelong treatment is given, and it can be managed very well. The other advices which are given are vaccination for other infections, respiratory infections, especially influenza, pneumococcal vaccine, and then weight loss and good dietary advices, so that this is how the B is managed for a lifelong. Hepatitis C is much, much better. only counseling needs to be given because the reinfection rate is very, very high. The mode of transmission of C is through these unsafe injection practices, and usually these are IV drug users which have this infection. So even if you clear by giving a 3-month treatment, they land up with reinfection. So a good counseling has to be given to them. Otherwise, this is a better virus and you do not require a lifelong treatment. So what is the current status of our hepatitis program is that it is there functional in many of the states, including Delhi, and very soon we are going to launch it with identification of the sites and centers. However, the drugs for hepatitis B and C are freely available by the Delhi State Health Mission, and anybody can procure them. So this program has started rolling out. The B and C drugs as well as the diagnosis is freely available to whatever sites have been made under this program. So I'll just summarize that in order to meet this ambitious target that by 2030 you have to reduce infections and mortality, Government of India has launched this program, National Viral Hepatitis Control Program. In this program, free diagnostics, free treatment, especially for B and C is offered. Our country is the only country where B is also included because most of the countries like Egypt, Australia, they only target hepatitis C. But in our country, we have the drugs available for hepatitis B. Only thing is that the state has to come up, make a proposal and start implementation of this National Viral Hepatitis Program. Thank you.
Thank you so much, ma'am. Thank you for the valuable information. I hope now we can say India is also working against hepatitis B and C. Thank you, ma'am. So going ahead in our today's presentation, I would like to invite Ms. Ankita Sharma, Assistant Professor from the Department of Nutrition and Dietetics, Faculty of Allied Health Sciences. Ma'am is a person who has worked, who has published many research papers on various clinical trials. She has done many researches in the nutrition department. She has already got the grants for various research projects. Ma'am is going to today, she is going to share the knowledge on the nutritional management in hepatitis. Of course, all the students would like to know how we being the nutritionist can reduce the burden of hepatitis. And she has done the projects with GlaxoSmith, and she was also the contributor of a book, and her area of interests are therapeutic nutrition. Of course, that's why she is going to throw her knowledge on the management of hepatitis, nutritional management of hepatitis. Thank you so much, Ankita ma'am. Thank you so much for sharing and sparing your time. The screen is now yours, ma'am. You can share your screen and we can start with the presentation.
Thank you so much, ma'am. I'll just share my screen. Am I audible?
Yes, ma'am, you are audible and visible. I'm waiting for your screen to get shared.
Sure, ma'am. Just a second.
Yes, ma'am, your screen is also visible now.
Visible, okay. Yeah, good afternoon, everyone. Today I'll be presenting about the nutritional management in hepatitis. And since today we are, in the previous session also, we are continuously talking about hepatitis B and C and what's the prevalence, how it can be treated, how about the vaccination status and all, what is the prevalence of this disease. So I will be basically touching upon the nutritional management, that how if one is suffering from hepatitis, what type of dietary recommendations can be given to the patient and what can be followed. Starting about, as we all are aware, this has already been touched upon, obviously, just to go again, that we all are aware that the liver is the largest organ of the body, and since it has a major role in providing it's a multifunctional organ which play an important role in carbohydrate, fat, and protein metabolism. So the functions are numerous, and they are very, very important functions which are played. And that's why if liver is affected, it plays havoc on the body. So the functions of the liver, we know it helps in glucose metabolism, cholesterol synthesis, absorption of vitamins, minerals, and it helps in amino acid synthesis, produce bile and all. So why do we need to protect our liver? Why are we talking about protecting the liver? Is because we are having numerous lifestyle changes with us, and because of them, we torture our liver in some manner. Like there are alcohol intake, excessive workload, smoking, different types of drugs, infections, stress, processed food intake, which is nowadays the consumption is very, very high, environmental toxins, not taking enough rest, poor nutrition, coffee, energy. So all these factors, they are contributing in some, it is basically teasing or creating a problem for our liver. Right now, obviously, their liver diseases are numerous and they are interconnected. But we are here to talk about, focus on hepatitis. So the liver diseases may be due to number of causes like infections, toxin, metabolic or nutritional factors, or maybe carcinoma. So talking about the hepatitis, which is inflammation of the liver, we have already been aware through numerous talks about A, B, C, D, E, the types and all. So coming to the causes of hepatitis, like it's due to virus or alcohol abuse, drugs use, or it can be hereditary, or maybe sometimes it's not known. So the symptoms of hepatitis are fatigue, nausea, a type of fever, yellow discoloration of the skin, eyes, stomach ache, dark urine, etc. Since we are talking about hepatitis B and C, so in particularly type B and C lead to chronic diseases in hundreds of millions of people, and together are the most common cause of liver cirrhosis, liver cancer, and viral hepatitis related deaths. So because these are the two hepatitis which are actually contributing to liver cirrhosis, liver cancer, and hepatitis related deaths. So an estimate of 354 million people worldwide live with hepatitis B and C, and for most, testing and treatment remain beyond reach because we are not aware about whether our liver is actually functioning normally or not. Since we know that liver, if it is partially functioning or functioning maybe at 25%, then also the person can be asymptomatic and can function normally. So the prevalence of HBV and HCV in India is estimated to be 3 to 4% and 0.8 to 1% respectively. And WHO has also told us that hepatitis B is a hepatitis B generally causes a mild or subclinical acute hepatitis, but chronic hepatitis or an asymptomatic carrier state, most symptoms last 1 to 3 months along with fatigue and can last longer also. So progression to chronic hepatitis is most common in perinatal infections and among children. Obviously, we know that the transmission is through blood and body fluids and all. I'm not going through that. Similarly, hepatitis C is the most common cause of chronic hepatitis and is the most common indication for liver transplantation. So acute hepatitis C is usually again asymptomatic, but many cases do progress to chronic hepatitis. Hepatitis C patients may also remain asymptomatic for 20 to 25 years before developing cirrhosis, which occurs in about 20 to 30% of the chronic cases. Now coming to the nutritional management part, why do we want to, why it is important to have nutritional management in liver disorder, particularly hepatitis? One is to relieve symptoms. We need to relieve the symptoms, also to aid in regeneration of liver tissues, and also to prevent further liver damage. So overall, the main goal of treating hepatitis is that a healthy diet is one that is low in fat, cholesterol, and sodium. And simple and complex carbohydrates and lean proteins can be given, which should be the base of each meal. So now focusing on the dietary part, since obviously the treatment, the medication are being given to the patients, and along with that, the dietary part has to play a role. So in a study, the main treatment for chronic hepatitis is interferon-based antiviral therapy, which often causes a decrease in appetite and energy intake. So it's due to the type of therapies the patients are getting treated with, there the appetite goes drastically low and the energy intake has to be increased. So hence nutritional support is required during therapy to prevent undernourishment, treatment interruption, and a reduction in quality of life. Also, moving further, in patients with chronic hepatitis C, nutritional support is expected to promote the effect of antiviral treatment. So we need to, in a study, it was shown that like supplementation of N3 polyphos inhibit HCV replication, and a low iron diet is effective in reducing hepatic injury. So various nutritional problems as well as clinical symptoms lie in liver cirrhosis, which is the end stage of chronic hepatitis. Complications of influence and prognosis. So therefore, the nutritional therapy is important in treating these problems. So first of all, talking about the energy, like what should be the approach for energy intake. So energy intake has to be high in the sense that we need to promote weight gain and also to ensure that we have maximum protein utilization. So intake can be around 35 to 40 kilocalories per kg body weight, or as per the requirement for desirable body weight. Since the patient may be immobile, so obviously the energy intake would not be too high in that case. So we need to monitor that what is the weight loss the patient is experiencing, and according to that we can monitor or we can bring the patient to the desirable body weight, since along with intake the appetite also goes too low. So modification of the diet has to be in such a manner that appetite has to be maintained in such a regulated in such a manner that the patient should take food, and at the same time we are providing adequate energy. Talking about the carbohydrate, it is required to prevent. Why carbohydrates are important? Since they're required to prevent endogenous breakdown of proteins, thus having protein sparing action. Since we want them for protein sparing action, we also need to increase the glycogen stores to improve the functioning and also to protect the liver against infectious agents. Since the liver has been affected now, so and we know that liver is a powerhouse, it stores all the nutrients, and if now, since it is not functioning properly, so we need to provide all the nutrients in a right manner. We do not have to stop any kind of nutrient, but we need to provide all the nutrients in the right quantity depending upon what is the situation of the patient, condition of the patient. So we need a daily intake of 300 grams of carbohydrate in the form of simple carbohydrate like glucose, sugar, fruits, or fruit juices can also be given. and starches like cereals and root vegetables are also advised to be taken. Also, eating foods with high fiber should be given, like fresh fruits, vegetables, lentils, beans, whole grains. They are basically categorized as healthy liver foods. And fiber is basically called as nature's broom to help eliminate toxins from the body. So in a study, again, people with hepatitis C have also seen with increased risk for type 2 diabetes. So it's important to keep a check on the sugar intake at the same time. So in that case, we can modify the type of carbohydrate which we can give. Talking about the protein intake needs to be increased to overcome negative nitrogen balance. Also, since the liver cells have been affected drastically, so we need protein for regeneration of liver cells and also to prevent fatty infiltration of the liver. So protein helps repair and replace liver cells damaged by hepatitis C. In other words, protein, obviously, we know it's an essential building block of your body. So needs to repair and replace tissues that has been damaged, not to limit the protein too much because it can result in lack of certain essential amino acids that is important for the body to function. So we need to focus on what type of protein we are targeting. We can give high biological value proteins, plus in combination, we can combine animal proteins as well as plant proteins together. Then talking about fat should not be completely restricted. Why? Because if we are restricting fat in the diet, we are making food not that palatable to eat. So around 20% of the total calories should come from fat. But we need to, again, modify the type of fat which we are giving. We need to avoid type of saturated fats or trans fats from the diet. Saturated fats are mostly found in animal products. We know that trans fats are generally in the processed foods, deeply fried foods and all. So we need to avoid highly processed, high fat, sodium-packed fast foods from the diet. In a study, chronic hepatitis C infection increases the risk for hepatic steatosis, and a high intake of dietary cholesterol contributes to this problem. And it's also associated with progression of hepatitis C-related liver disease. So individual on a dietary, it was seen that individual on a dietary regime of the reduced in fat, that is 23% of calories, and cholesterol, 185 milligram per day, experienced a reduction in liver enzyme elevation and improvement in immunological abnormalities known to contribute to liver inflammation in patients with CHC. So it is seen that we need to restrict cholesterol and also modify the type of fat which we are giving. We can also depend on MCTs, medium chain triglycerides, so that the liver can take rest, and at the same time we are providing fats to the body. Again, talking about an important aspect which is always ignored, since we always talk about macronutrients, not talking about micronutrients, vitamins and minerals. Vitamin A availability is low due to a decreased intake and impaired fat absorption. And we can provide vitamin A in the form of carotene. So carotene-rich foods can be given, like green leafy vegetables, deep orange and yellow colored vegetables and fruits in the diet. In liver disease, the prothrombin time is increased, which may be corrected by given vitamin K. Also, B group vitamin requirements go up because we are increasing the energy requirements also. So it's required in the energy metabolism, and higher amount of vitamin C are needed for tissue healing. So what to avoid? Basically, foods having high sugar and salt retain fluid in the body, so we need to restrict it. We need to avoid alcohol as it can act as a throwing gas on a fire with liver disease and increases damage. So studies have shown that hepatitis C progression occurs in patients as a result of accelerated hepatic iron intake and the oxidative stress caused by iron catalyzed free radical production. Along with phlebotomy, a low iron diet helps lower the risk for hepatocellular carcinoma in these patients. So we can have steamed green vegetables. We basically have to focus on vegetarian diet, mostly focusing on cereals, pulses, and fruits and vegetables. So fresh fruits, legumes, plenty of drinking water, whole grains, organic chicken, fresh vegetable juice, fish, and all can be given. What to care for? There are again some of the micronutrients which we need to focus on, since it is seen that the metabolic abnormalities related to 4 essential trace elements in liver disorders are focus on zinc, copper, selenium, and iron. And vitamin D deficiency is common in patients with chronic liver disease, and these patients may have a reduced ability to convert vitamin D to its active form. So that's why if we are focusing on intake of more of fruits and vegetables, so we do not have to we do not have to be bothered about each and every nutrient, because if our diet is having ample amount of fruits and vegetables, so all the micronutrient requirement will be covered on its own. So adequate B12 status helps with the clearance of hepatitis C from the circulation of infected patients. However, overly high B12 serum levels may also foster viral replication. So, and is associated with concentration of hepatitis C RNA levels. So it's important here to monitor the B12 level that we need to provide also, but at the same time, not in the higher amounts. Lastly, the coffee consumption may be helpful. The studies are being done on coffee consumption, because there was initially, it was believed that you should not give tea and coffee, but at the same time, studies are coming up that coffee consumption can be helpful, because it reduces oxidative DNA damage, increase death of virus infected cells, stabilizing chromosomes, and reducing fibrosis. So moderate daily unsweetened coffee ingestion is a reasonable adjunct to therapy for non-alcoholic fatty liver patients. Thank you. Obviously, the topic is broad enough, but in 10-minute scope, I could focus on these macro and micronutrients. Thank you.
Thank you so much, Ankita ma'am. Yes, in 10 minutes, these many nutrients can be covered. So going ahead, I would like to invite Dr. Aisha from the Team Empathy Project, and she will be taking us for she will be administrating the I pledge and oath ceremony for this particular hepatitis B and C. Ma'am, if you can unmute yourself.
Good afternoon, everyone. First of all, I'm really sorry for the initial glitches that we had. And now I request you all to raise your right hand and please read the pledge after me. I pledge that I will try to keep my liver healthy.
I pledge that I will try to keep my liver healthy.
I pledge that I will get myself and my family tested and vaccinated.
I pledge that I will get myself and my family tested and vaccinated.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will generate dialogues with my colleagues on hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
Thank you. Back to you, Ms. Ankita.
Thank you so much, ma'am. Going ahead, I would like to invite our panelists, Dr. Umesh Yadav, a professor from ILBS, Dr. Manya Prasad, assistant professor from ILBS, Dr. Archana Ramalingam, scientist from NIE Chennai, Dr. Ajit Bhadodria, associate professor from AIMS Rishikesh, Dr. Ekta Gupta, professor from ILBS, and Ms. Ankita Sharma, assistant professor from MRIIRS. Ma'am, thank you so much all for joining in. The forum is now open for the discussion. I know that none of the questions has been posted in Q&A section. The students were sending me the questions. I have already posted the questions in the chat box, but I'll read the questions one by one so that all the panelists can answer the questions. So the first question is, what is the main reason or the challenge that we are not able to have hepatitis C vaccine, keeping in mind that we have already developed COVID-19 vaccine within no time? Dr. Umesh, if you can answer this particular question.
Dr. Ekta, are you there? Okay. Well, what is happening is that we are trying our best. Scientists are trying their best to develop the vaccine for hepatitis C. There are inherent structural issues with the virus which we are dealing with, and hence there's a delay in development of vaccine. But it's a novel laureate work. Anyone who does it, he'll get a Nobel Prize for that. Thank you. Over to you.
Yes, sir. Of course. Hopefully, India will do it in next 2-3 months, so that we will get that Nobel Prize. So, sir, next question is: can Moringa cure hepatitis B? Dr. Ankita, Ms. Ankita, if you can answer that. Can Moringa cure hepatitis B?
Yes, Moringa can. It is seen because there are various studies which have been done, and it has seen that Moringa has some of the properties which can help in fighting, basically ridding of the toxins from the body. So it is seen that Moringa has positive effect on hepatitis B and C.
Thank you, ma'am. So next question is: are patients undergoing treatment for HCV? HCV is at risk for HCV reactivation? Dr. Manya, Dr. Ajit, if anyone of you can answer.
Yes, there is data suggestive of that there might be reactivation of hepatitis B in some patients who are co-infected with hepatitis C and are on treatment. So yes, that's true, but the percentage is not that high, that worrisome.
Okay. Dr. Manya, if you can tell the person that just made a question, like who is the person who cannot receive or who should not receive hepatitis B vaccine?
So hepatitis B vaccine is largely safe. Most groups, there is no contraindication. So even in pregnant women, lactating women and children and newborn, of course, it is indicated. I think the only contraindication is a severe allergy to a previous dose of hepatitis. But it is, so if somebody has a severe allergic reaction to a previous dose, that's the only situation you would not give more doses. It is largely a very safe vaccine. So pretty much there is no contraindication for this. Even immunocompromised people are given hepatitis B vaccine.
I'll add over here that by and large what Dr. Manya said is absolutely fine. Giving a vaccination to an immunocompromised patient, giving vaccination to a person is a one-to-one issue. Okay. So the treating physician is the best person to take a final call. What we are talking about is a overall public health approach for the vaccination. And by and large, all these vaccines are safe and they have been tried out in large number of countries. And we have a universal approach to the hepatitis B vaccination That means each and every person in the country should be vaccinated. There are issues that sometimes person takes a one vaccine and then forgets about it. Then he comes for second vaccine. So first vaccine is first vaccine, second vaccine is second vaccine. So please ensure that these things are being taken care of. Thank you very much.
So there is one more question, like how many different genotypes of HCV exist? Can superinfection with more than one HCV genotype occurs?
It's a difficult question. Dr. Ekta, Dr. Ajit, you would like to contribute?
So there are I think around 7 genotypes of hepatitis C. Most common is genotype 1 and 3. And co-infection with 2 different genotypes, I mean, this is something which is very tricky. But yes, there are different genotypes, and initially there was different treatment also for these genotypes. But now we have pan-genotypic drugs, so we do not need also even to go for genotype testing for even for any patient. We can directly go for these drugs, and they are equally effective in all genotypes.
Dr. Ajit, they have
Yes,
a very specific question. Can a person have infection from 2 or 3 genotypes? Okay, so answer is, ma'am, we do not have the answer now. At least we are not aware about that answer to that question. However, it has been seen that to a different level, the patient with B and C, they can have HIV, they can have B and C together. That is possible. But to answer specifically to your question, that a person can have, whether a person can have HCV infection of 2 different genotypes, we don't have an answer. But we assure you we'll post it on the your Gmail. You can circulate it to all the members. We apologize for that.
Sure, sir, sure. That would be a great help, sir. So one more question is, like, can I have a patient with normal liver enzyme level can still have chronic hepatitis C?
Yes, that is possible, because whatever we are talking about is normal course, what we are finding. But here also we do have on the right side of the standard deviation few cases which are absolutely normal, but they have disease per se. And some on the other side, they're absolutely normal, no disease, nothing, but their serum enzymes are increased, right? So there are issues with these type of situations, but we must understand that by and large, in all cases where there you have a person have hepatitis B and C, person have a chronic infection, the enzymes would be raised. Okay, thank you. Over to you.
So, I think we can take this as the last question of the forum, as we are already running off the time. So last is, why is large dose of hepatitis B vaccine is required to be given to immunocompromised people, such as people who are on hemodialysis or patients who are HIV positive?
You want me to answer?
Yes,
yeah, please, go ahead.
Like in HIV patients or immunocompromised disease patient or any patient who is on drugs which can suppress immunity. So why we need more the dose of vaccine is because the seroconversion will take time. The person is already weaker in the immunity part, so getting development of sufficient amount of antibodies will take more amount of antigen. So that's why we increase more dose we need more dose for these patients.
Okay.
Issue is, let me complete. It is not the quantity of vaccination, it's the frequency of the vaccination which is more important. ऐसा नहीं है कि आप 1 ग्राम दे रहे हो मुझको तो 5 ग्राम दो immunocompromised, ऐसा नहीं है. What is happening is that we have more frequency of vaccination so that the antibodies can be produced and that person can be protected from the possible infection of hepatitis B and C. Thank you.
So now on this, I also have a question. How many can be the maximum doses what can be given to a person if he or she is immunocompromised? Maximum number.
Oh God, you are asking very difficult questions. Dr. Manya, you would like to respond?
So in immunocompromised, the dose is increased. The schedule is the same as the 3-dose schedule that is there in normal individuals. In terms of the maximum number, there is no such thing as over vaccination. If the person gets more vaccine, it's not like it's going to be very harmful. But the schedule that is recommended in terms of doses is the same as the normal schedule. Dose is 2 ml. So it's double the dose.
Or we can even check for antibody and titers also, like whether we have achieved a significant level of protection.
Non-responders, very often people who are immunocompromised are non-responders because their immune response is weakened. So in that case, we would check the serological response and we would follow the sequence by judging the response that is there in terms of the titer.
Okay, thank you so much, ma'am. So with this, we are towards the end of this particular webinar. I thank all the panelists for answering the questions. So to give the conclusion to this particular webinar, today's day started with Dr. Archana Ramalingam. Ma'am gave us the complete site of how the HPV and HPC are being screened, what are the screening tests which are available, and what are the types of vaccines, what should be the schedule of vaccine, what are the various sites of administration, and who are the key targets of hepatitis. And she also told about the health education for hepatitis of community level, and she told us about the poster competition or cartoon making competition that has already been covered by IBLS, and I hope next time you cover that, please include our Emmanuel students in that particular competition. They will also be, very blessed to at least participate. Then the next session was taken up by Dr. Ajit Singh Badodria. Sir told us about the parental transmission of hepatitis B, C, and D. What are the routes of transmission? Why, and how the infants can be protected by this particular disease? What are the anti-TBS titers? What are the doses? And what is the birth dose? And what is the booster dose? And how this get transmitted? So every high-risk groups and practices for prevention was told by Dr. Ajit Singh Badodria. Next session was taken up by Dr. Manya Prasad. Ma'am told us about the types of hepatitis, how they get spread, why should we focus on this, and she gave us a very good insight of all the data which are present over internet, and she compiled everything in a very beautiful way for how the data is creating the burden over India, and what is the burden according to WHO, what is the percentage of people who are vaccinated in India, and how Indians are our proud IBLS institution is doing to promote and to, for the betterment of this particular data. Then next session, fourth session of the day was taken up by Dr. Ekta Gupta. She told us about the National Viral Control Program in India and what is the strategy to eliminate HBV and HCV by 2030. How the program was launched, what are the aims of the program, and what is the organization structure of the program. This particular session was taken up by Dr. Ekta Gupta. Last session of the day was taken up by Ms. Ankita Sharma. Ma'am told us about the management of hepatitis B in nutritional way. So ma'am told us what is the role of micro and macronutrients for treatment of hepatitis, how we can keep our liver healthy. And once if we have got hepatitis, still what are the dietary changes we can make to prevent ourselves from the secondary complications of hepatitis. So all the sessions were very knowledgeable. I hope my students must have gained a lot from these sessions. Now going towards the vote of thanks, or that these are just words, but we really like to thank you all. Thank you all for sharing your information. Thank you all for creating this platform. Dr. Aisha, thank you so much for joining us, and thank you so much for giving us this platform to learn. Over to you, Rizvi sir, for the final vote of thanks.
Thank you, Dr. Ankita. Indeed, it was a very good session and we enjoyed thoroughly. And I'm very much thankful to each and every one of you, all the speakers, all the participants. To name them, Dr. Ajit's session was very informative. Then we had Dr. Amanya, Dr. Archana, and Dr. Ekta. All of them have been well versed with the knowledge, and we have taken something from them. And my vote of thanks will go to Dr. Kapil, Dr. Umesh Kapil, along with Professor Dr. S.K. Sareen, who have selected Manav Rachna to be one of the institution for spreading this awareness. And I thank Dr. Aisha and Dr. Namrata, who have come all the way from ILBS to take this agenda of empathy and spreading the awareness amongst us. So once again, I'm also thankful to the head of the department, Dr. Divya from Department of Nutrition and Dietetics. She has really given us her time. So all in all, we are looking forward to have more such sessions, and we will be joining there. Once again, thank you very much, Professor Umesh Kapil sir. Thank you very much.
सर हमारे को कुछ और वेबिनार्स करने हैं, वो आपकी ब्लेसिंग्स चाहिए सर.
पाइपलाइन में है सर. आई एम प्रिपेयरिंग फॉर दोस.
Sure, sir. Thank you very much, sir. Most grateful to you. Ankita ji, आपने बहुत अच्छा compare किया. Very good. We like to have you with us in subsequent sessions also.
Thank you so much, sir. Thank you so much for your time.
Thank you very much.
अंकिता को रजिस्टर कर लिया आप लोगों ने.
Thank you so much, sir.
They have got very good tuning. Aisha and Ankita, as both of them, they were speaking the same thing कि हम एक दूसरे को चाहिए हम लोग.
Yes, sir.
Thank you so much, sir.
Thank you very much, sir.
Thank you.
So with your permission, Rizvi Saab, can we close the webinar?
Yes, sir. Yes, sir. Thank you very much.
My pranam.
Thank you, sir.
I'm really grateful and thankful to all our eminent speakers who take out time from their busy schedules and always be a sport and give us such important lectures and help us in disseminating this knowledge. I am thankful to Dr. Rizvi from Manav Rachna University, who give us the platform to help his students in disseminating this knowledge. And also to Miss Ankita, I must say the time she takes over, I sit back and relax in my chair and then let her handle the entire show. I'm also thankful to the entire team of Empathy for getting these seminars done in such a successful manner. I now request all the participants to click on the post-webinar link, which is available in your chat boxes and also which is visible on the screen. Alternatively, you can scan the QR code. Please fill up these forms so that you can get your certificates. You will be getting your certificates within a span of 3 days. Kindly fill up these forms. Just a small questionnaire of, it will just take 2-3 minutes, just a couple of minutes. Also, you can post your queries, any feedback, any way you can help us in conducting these seminars or be a part of Empathy campaign. You're most welcome. So kindly mail it to us. We would be grateful. Thank you.
Thank you, Aisha. Thank you.